Hi, I'm Kim Palmer with Emory's Woodruff Health Sciences Center. With me is Dr. Jenny Mascaro of Emory's School of Medicine, Department of Family and Preventive Medicine, and the lead scientist in our research program at the Woodruff Health Sciences Center, Department of Spiritual Health. Also joining me is Dr. Chuck Raison, who serves as our Director of Research and who also holds an endowed chair in human ecology at the University of Wisconsin-Madison, visiting professor in the Center for the Study of Human Health at Emory College. So welcome you two. And I just wanted to say I'm delighted to be here today and talk a little bit about our research program at Emory. And I wanted just to start off with a basic question about how did research on chaplains and spiritual health come to be an interest of yours? Like, how did you get to this program?
I guess I can start. So, I've had a long-term interest in the interface of human spirituality and mental health. I'm a psychiatrist, so I'm interested in mental health. And that had mostly manifested across the years in an interest in Tibetan Buddhist meditation practices. I'm not a Tibetan Buddhist, but I've been very impressed with especially some of their more advanced techniques, just very interesting ways of thinking about how the brain and the body together might be stimulated to enhance well-being. And so I'd been at Emory, for 12 years in the first part of the 21st century, and had done research work with Geshe Lobsang, Tenzin Nagy. We had really developed kind of a program looking especially at compassion meditation. Then I left, I went to Arizona, I went to Wisconsin, and personal circumstances pulled me back to Georgia on a part-time basis about 5 years ago. And word that I was kind of hanging around back in Atlanta got out. And George, sort of chased me down. We had this fantastic lunch together, and he had this deep interest in seeing whether or not some of the secularized insights from Tibetan Buddhist practices might be able to be applied in chaplaincy training, specifically to sort of enhance chaplains' ability to manifest compassion in their interaction with patients. And I was immediately fascinated by this because I'm a doc, and the healthcare system is often very short on compassion. And those of us who are working in direct healthcare, you're overwhelmed with medical records and this and that and IVs. And, it'd be great if we were all compassionate. But the amazing thing about chaplains is that it really is their job description. They are there to sort of provide that to patients as a means of enhancing their well-being. So I very quickly saw that this could be a transformative place for sort of meditation research in particular. So that's how I started. And of course, I've subsequently gotten more interested in chaplaincy in general. It's a fascinating area. But I knew, though, of course, that I wear so many different hats, and I'm not at Emory full time, that for this to succeed, we really needed somebody that had the capacity to take on this research program. And I had worked with Dr. Mascaro over the years on the compassion meditation work back in the sort of mid 2000s. And so when I agreed with George that I would take on this role of Director of Research on Spiritual Health, literally the first thing I did was reach out to Jenny and say, hey, I know this is an area of shared interest. Would you be interested? I think there's a real opportunity here. So that's how I came into spiritual health. But we can ask Jenny, since I initially dragged her into it, and she is really, Kim, you and Jenny are absolutely playing the leadership role in all this work.
Okay. Yeah, go ahead, Jenny.
Sure. Yeah, I was very happily dragged into this, and my entree into this work is similarly winding. I'm a biological anthropologist by training, and my area of interest is in the brain and body systems that support social connection. And so I started my research career really interested in more kind of foundational questions, such as, what happens to the brain and body when someone practices compassion-based meditation practice. But it became really clear right away that when you ask those kinds of foundational questions, you are also asking health questions, because our health and well-being is so intimately tied up with our social connections. That's become quite clear over the last 2 decades from work that Chuck has done and other, really prominent researchers who have shown really clearly that having rich and deep social connections are as important for our health and well-being as any other healthy behavior that has been studied for many years, like smoking and diet and exercise. well, social connections are right up there. So those were my interests. And then it's funny how shared lunches come into play in our research story. I will never forget having a lunch with Chuck where he said, hospital chaplains see about 120,000 patients a year at Emory. And I think my mouth just dropped open because it's so clear when you hear that kind of data that hospital chaplains are doing a ton of the work in many healthcare systems, but especially Emory Healthcare, to cultivate and foster not just spiritual growth and spiritual meaning among patients, but also the social connections and social support that we know are so important. So, my winding path went from these kind of foundational questions to much more applied. Can we understand in a hospital system where patients and staff and providers are bombarded with suffering and really often at their worst moment in life, can we understand how spiritual health clinicians cultivate the social connection and the spiritual meaning and buffering that can help really make a difference between a terrible outcome and a outcome that becomes infused with more meaning and support.
Yeah, thanks. So one thing I just want to point out is your 120,000 consultations a year. That's both patients and staff members, but we do see a lot of patients. And of course, I operate as a chaplain as well as a researcher within the Emory healthcare system. So, I know that the team sees a lot of patients. And I'm interested in your comment about the, it hinges on a lunch with Chuck. Jenny, I don't know if you remember, but when I was in the Rollins School of Public Health as the Transforming Chaplaincy Fellow, getting a Master of Science in Public Health, I attended a lecture that you spoke at. And I came up to you afterward and I said, hey, I'm really interested in this work. I hope I get to work, with you at some point. And I was thinking, these people who give these lectures, they probably have hundreds of students come up and pester them because they need help with their practicum or whatever it is. And I just, I look back on that day and realized that, we were already, you and Chuck and George. And I know, Chuck, when you mentioned George, that's George Grant, our director, executive director of the spiritual health department. But that we were all already kind of connected and these connections were bubbling under the surface.
I remember that so well because it was memorable, but also I think you gave me your business card, and every now and then I run across it. And I remember, I think I was about 2 weeks into my current job, and I sort of got pulled into giving a talk, and I didn't know what I was doing, and sort of bumbling through. And you came up, and I think it's inevitable that when people have these shared interests, you're going to cross paths and sort of recognize potential. So yeah, I remember that very fondly and very well too.
Yeah, like a recognition of kindred spirits, or at least kindred interests. I wonder if you all could talk a little bit about our research program and just kind of give an overview, like what's going on, what's exciting, what do you think is upcoming, wherever you want to take that.
Let's see. Shall I start? And then
Yeah, go ahead, Jenny. Why don't you start?
Sure. So, I think that we could imagine our research program began with a lot of information gathering. There has not, what became clear is right away is that there is some really rigorous research done in the world of spiritual health, but that world is growing, and so it became clear that what we were doing was going to be kind of on the forefront of of the research efforts in spiritual health. So a lot of our early research was really more exploratory, kind of getting our research feet underneath us. And so I think of your thesis, Kim, where we were really just trying to get a handle on the contexts of distress in the hospital among hospital patients. So we were doing a lot more kind of exploratory research to understand what are the contours and situations that sort of exaggerate the feelings of distress. As we put it in that study, what burdens patients' hearts when they're hospitalized? And in order to understand, all right, what if we want to understand what chaplains are doing and how they're most effective, we need to understand what are the problems that they're trying to help patients overcome. So I think our early research was quite exploratory, but then we were really fortunate to get a grant from the Mind and Life Foundation to do an interventional study, a sort of a rigorous, experimentally designed research study, where we capitalized on the fact that George Grant and others at Emory Spiritual Health were beginning to incorporate a compassion meditation program, cognitively based compassion training, into the pastoral education that was already going on and ongoing at Emory Healthcare. So what we did was we did a sort of a quasi-experimental design where, rather than all of the chaplains getting this compassion training right at the front end of their residency program, we randomized half of them to get it right away and half of them to get it later in the semester. And what that allowed us to do was examine both the impact of that program on the chaplains, but then really interestingly, we were able to sort of track what is the downstream impact of that program on the patients that these chaplains then see. So the last 3 years now have been a look at this this study and the design and the data that have emerged from it. And it's a really rich data set. It's hard to, I think we could spend our entire 20 minutes talking about the data that we've collected and what we're learning from it. But that, as I see it, we sort of moved from this exploratory phase to this more experimentally designed phase where we really are trying to examine the effect of changes. What does it mean to change the way chaplains are trained and impact the way chaplains interact with patients?
Yeah, so that one of the things that I'm cognizant of in that trajectory is that part of the reason we did that initial exploratory work to figure out what are the burdens and stressors within the inpatient population was so that when we intentionally developed an intervention based off of the CBCT insights, which we call compassion-centered spiritual health, or CCSH, we were looking to see, what is it, if we develop an intervention, what are we trying to target? What are we trying to have the chaplains, address in terms of people's distress in the room? And one other kind of little bit of the history that I find kind of interesting is that Maureen Shelton, who is our director of education in our CPE center, had taken that CBCT course. And in her mind, she thought, wow, this would be great to train our chaplains. It's so helpful in helping me control my own busyness in my mind, and helping me recognize, that I don't have to, that I can provide self-care in the moment. I don't have to, take on guilt or fear or those kinds of things. I can redirect myself away from those into more positive kind of mind frames. And that would be really helpful for the chaplain residents. And so that's how that kind of training got started. Chuck, I feel like there's something tickling the back of my mind too, that you have talked about. I was hoping I could capture it so I could ask a question, but it's gone.
Talk about a lot of things. I think one of the things I just from a 10,000 foot view, I think one of the things that's really interesting about what we're trying to do is actually try to bring scientific methodology to bear on understanding how can we optimize the capacity of chaplains to, frankly, do their job. I mean, really, when you think about it, if you think about like what is the overarching thing that we that spiritual health clinicians are aiming to do, they're aiming to address the spiritual health needs of people in bad times, right? And we've talked a lot about what we think about spiritual health and what is spiritual, and I think we have a shared understanding that although it may come in many flavors, that it really is this sort of universal human drive for connection and for meaning and sometimes for transcendence, the sense that life offers more than what's apparent just on its shallowest surface. And so figuring out how can we optimally address those desires and needs of patients in ways that then promote their health is really interesting, right? And so part of what we're doing is not just testing whether our already produced program, be it CBCT or CCSH, not just is it an improvement on standard chaplaincy training, but also I think to use the scientific method to ask, are there ways that we can improve these interventions? How do we think about bringing science to bear so that we can really optimize the capacity of the spiritual health clinician in the room with the patient? And that part is really interesting to me, because it becomes this sort of iterative process where you begin to look at just empirically, what are the things that chaplains do and feel and are that translate into better, patient outcomes. So it's a really cool thing. And I think one of the things that I've so enjoyed about working in this space is that it's got a pragmatism to it that is refreshing. A lot of times in fields such as meditation, any of these fields where there's a sense that there's some sort of, kind of wellness practice that could maybe transform the world, I've always found this risk that they sort of get oversold, overblown, they're going to be good for everything. And a lot of times what happens then is that the studies get very diffuse and they don't really show things. You don't know what you're looking at. One of the great things about working in the spiritual health space is we do know exactly what we're looking at. We are working to find ways to develop tools, training tools for spiritual health clinicians to take better care of themselves and be healthier within a chaplaincy position, and B, to have tools to enhance their ability to transform the health status of patients within the realm that spiritual health has to access that. And so, I think this is something that I'm not going to speak for Jenny, but I think it's true for her too, that one of the things that really attracts us to this work is that it's got these really beautiful outcome potential measures that are, that it's not saving the whole world and it's not overblown that way. It's, let's really see if we can, use these methods to get spiritual health to be part of, sort of how we medically treat people. And that to me is just really fascinating.
Yeah, and that goes back to our focus on looking at assessment and then an intervention that's targeted to what we found in the assessment. And then
Exactly.
of course, what we're doing with our CCSH intervention is then measuring the outcomes. And I like your description of the iterative process. That was actually what I was going to bring up that I couldn't call to mind. But this idea that we investigate, what are the issues that we're trying to have the chaplain address, and then we develop an intervention, and then we test the intervention, and then we revise it and then retest it, so that it's actually the development of the intervention itself is scientifically grounded in this iterative approach.
Said it better than I did. That's it. That's exactly right.
Yeah, like I like to say, I was channeling you.
Yeah.
So what are some of the things upcoming? Jenny, I know you got the K Award. Maybe you could talk about that a little bit and what you're anticipating for your research for that.
Sure. So the work that we've done so far, we imagine that we've sort of cast this really wide net around the hospital system to try to understand with our data collection. So we've tried to understand, all right, we have this group of spiritual health clinicians going around seeing patients in all kinds of different ways. So maybe that's when the patient has first arrived. Maybe that's because the nurses have called the chaplain because the patient is in an acute crisis event, sort of all over the map. But we know that there are some patient populations where they're going to be hospitalized for a certain amount of time. There's a really clear trajectory whereby many of them feel, a lot of loneliness and isolation potentially, and a whole suite of symptoms that come with treatment. So these are patient populations that have a clear trajectory, and so we're sort of thinking, all right, well, we've looked at this. We've started to look at the potential for chaplaincy intervention in, you know, a one-off kind of situation that chaplains so often encounter. But what about these situations where there may be a more enduring relationship between a chaplain and a patient? And so the first look at this that we'll do is we received an NIH award from the Institute for Complementary and Integrative Health. So this is the institute that funds a lot of the research on mind-body approaches like mindfulness meditation or yoga or compassion-based meditation practices. And they have funded us to do a study of iterative or repeated interactions and delivery of this compassion-centered spiritual health intervention delivered by hospital chaplains to patients. And in particular, these will be patients who have blood cancer and are receiving stem cell transplant. So this was a patient population that we identified because we know that during stem cell transplantation, they're going to be in the hospital for 2 to 3 weeks. They're going to be quite isolated oftentimes, and they're going to face a whole suite of really distressing and uncomfortable physical symptoms. So this is kind of a perfect storm of facing this suffering, but facing it in a situation where you're often alone. So can we bring a chaplain interaction and a chaplain intervention to these patients in a way that's really, you know, consistent, where we have this tool in our hospital tool belt for patients that we know are going to be there. So that's our next look. So we're sort of moving from this wide net where we're looking at, you know, brief interactions between chaplains and patients. Well, now we're going to look and see what happens when we bring a heavy dose of compassion-centered spiritual health to patients during these times where we know that they could potentially really, really benefit from this interaction.
Yeah, so that heavy dose comes from the repeated contact and the kind of the ongoing application of the intervention.
That's exactly right.
You know,
Yep.
through the patient's trajectory in this really difficult hospitalization.
Yep. Exactly.
Yeah, one other thing that you know, comes to mind for me for something exciting that we had been doing as well, as kind of like expanding off of that initial you know, study, was the development of CCSH to be delivered by the chaplains or people trained in it, not just at the individual kind of bedside level, but in a team setting. So, you know, we had been exploring that in our cancer center where, you know, we took a look at whether or not the CCSH for team intervention was helpful for clinical research coordinators within teams. So for example, the research coordinators that worked with the breast cancer team or the GI team or lung cancer or whatever. And there's been, I know, other team delivery of that program for, you know, reducing burnout and increasing well-being in other kind of cancer team settings. For example, the entire GI team that would be interdisciplinary and so on. And some of that is still ongoing. So anyway, I'm excited about that work, about the data that we've already collected. I know we've got a couple of publications, you know, kind of in process, in review. Excited to see those come out in print and disseminate some of that information. So anything else that we want to talk about? We've been talking for a little over 20 minutes now, and I just wanted to sort of see if there's anything else anybody wanted to drop into the conversation about our work.
I'll just say, you know, that I think it's really amazing how we've sort of, I was saying this yesterday at another meeting, we've had this really big first wave of work. Kim, your work with, you know, figuring out what actually bothers patients in the hospital as a hugely valuable in itself, also as a preamble for them thinking about, well, how can we target interventions? The PEACE study that Jenny mentioned is, you know, semi-randomized study funded by Mind and Life. And y'all, both you folks have been so effective at getting papers out. I mean, it's amazing how much scientific material has been reported on already. And I think one of the interesting things is that we're now at an interesting juncture where, you know, Jenny talked about the bone marrow transplant and the iterative, you know, CCSH, you know, possibilities. And you mentioned the work with teams. And I think one of the really interesting things is that I think that in the next couple of months, we'll probably also begin to frame these questions of, what's the next, is there anything else we're going to add to the next wave, and how are we going to do it? But always around this idea of trying to show that we can optimize how spiritual health is delivered. And I mean, I'm fascinated by, and this again, George, our fearless leaders view that spiritual health really is medical health. And that, I think, I didn't say that adequately enough when you asked me that first question, because that was one of the things that immediately captured my interest. I'm basically kind of an evolutionary science guy. And it really is from that perspective that I'm utterly convinced that humans have this evolved species typical sort of craving or need or thing within them that we call spiritual, that it doesn't, what the truth of those longings are, that's not a scientific question, but the fact that this longing for meaning, for purpose, for connection, for transcendent exists to various degrees within almost everybody, I think is incontrovertible. And, it lines up with what Jenny was talking about, the power of social connection in health, where it should be very clear that social connection is a life or death thing for human beings. And I think the spiritual health is sort of part of that in some way, that it really should be part of healthcare, and figuring out how to do that without getting doctrinaire or alienating some people. There's a lot of really interesting complexities that are very fertile fields for research. But that core idea that human beings have a spiritual element, the way we've defined it, as this sort of longing for transcendence and purpose and meaning, and finding ways for a clinician to optimize the interaction between that spiritual drive and people's health, is one of the most fascinating things I can think of for anybody that's interested in the sort of human side of health. So I think one of the things that would be really fascinating to watch over the next year is how we then continue to explore ways to, empirically study this.
Yeah, one of the things I really appreciate about CCSH, our intervention, is that it's suitable to be targeted toward people of any religion or no religion.
Yes.
And that when people are religious, the chaplains can kind of leverage that into the intervention to kind of draw forth those specific resources that are applicable, or sacred texts or whatever within that religion. So it's applicable across the board, whether people are religious or not.
Yep.
So I really want to thank you both for joining me today for this conversation. And I look forward to, seeing you at our next time, and,
Yep.
Appreciate that, and take care.
Thanks, Kim.
Nice to talk with you both.
Right.
Thanks.